You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 25th, 2025. This week, the VENTOUX study of endurance athletes, the 10,000-step myth was not busted, rate versus rhythm control for atrial fibrillation, and GLP-1 drugs and observational studies. First up is the VENTOUX study. The group at the University of Leeds have published an interesting paper on endurance athletes' cardiac fibrosis and ventricular arrhythmias. They cheekily named it the VENTOUX study to correspond with a recent Tour de France stage that finished on Mont Ventoux this week. Now, I've climbed Ventoux. It took me 1 hour and 42 minutes. Tade and Jonas did it this week in 54 minutes, a record by a minute. Now, imagine loving the notion of climbing a 10% gradient for well more than an hour, and you will understand the mindset of older endurance athletes, which is relevant to this study. Thinking that this sort of exercise is fun is sort of a disease. People who do this day in and day out for decades have an affliction. I know because I do. We're like rodents who, when given a wheel in our cage, will run on it for no purpose other than to just run on it. Now, before I say anything else, I want to start with the fact that exercise is one of the pillars of health. It's in every expert consensus document, and there are oodles and oodles of observational studies that correlate exercise with survival and longevity. But 60-year-old people who cycle or run more than 10 hours per week for decades are not normal exercisers. For instance, if you do a 1-hour ride 5 days a week, to get to that level of exercise, you have to do a 5-hour ride on the weekend or 2 3-hour rides on Saturday and Sunday. That's a lot of exercise. Now, a number of years ago, I co-wrote a book in the popular press called The Haywire Heart, in which my chapters were basically narrative reviews of the cardiac effects of all this extra endurance exercise. The one single observation that got me interested in this topic is that endurance athletes have a heightened relative risk of getting atrial fib and, crucially, electrically and structurally, their atrial remodeling resembles that of a person with obesity and hypertension. Isn't that wild that the end result of disease with high levels of endurance exercise and cardiometabolic risk factors look the same? But AF is not the topic of this paper. Endurance athletes can also develop both myocardial fibrosis, or SCAR, and ventricular arrhythmias. And the ventricular arrhythmia story is less fleshed out than the AFib story, perhaps because it is less common. But again, similar to AFib, you have this paradox. Endurance exercise seems to correlate with SCAR that's also seen in healed myocarditis and other cardiomyopathies. And so something amazing for health, regular exercise, perhaps can be detrimental in high doses. And we all know that myocardial scar of any sort can predispose to ventricular arrhythmias, which can in rare cases lead to sudden cardiac death. Now to the VENTOUX study. The Leeds group recruited about 100 endurance athletes and 27 controls with the purpose of studying MRI, CMR, and monitoring for ventricular arrhythmias with loop recorders, ILRs, over 2 years, and all participants had to agree to an ILR implant, which is likely an important factor in the study's interpretation that I'll come back to. I have to say that this study is a great effort, and I congratulate the authors. The average age of patients was 60 years. All were men. None could have symptoms of any heart disease to begin with. And the athletes were pretty strong. The functional threshold power, what can be held for an hour, is 244 watts. Now, that's not close to elite, but it's not Mickey Mouse either. Now, another factor was that the Leeds group is a well-known and they're experienced in imaging. So the MRI imaging, I think, can be trusted. An expert in imaging told me that these are likely real findings. And here are the top-line results. Nearly half, 47%, of these athletes had myocardial fibrosis on MRI. The vast majority had inferior lateral location of scar. Now, the main way the authors display their results is with two groups, those who had scar and those without scar. About 1 in 5 athletes overall had some ventricular arrhythmias noted on an ILR during the 2 years of follow-up. And if you had fibrosis, you were 4.7% higher relative risk of having a ventricular arrhythmia, but importantly, the 95% confidence intervals were wide, and the increased risk could go from just 80% higher to 13x higher. Athletes with fibrosis were slightly older than athletes without. This was like 62 years plus versus 57 years. Athletes with fibrosis exhibit a greater prevalence of PVCs during exercise testing than athletes without fibrosis. It was 71% versus 42%. Next finding is that all 3 of the athletes who had VT longer than 30 seconds, which we call sustained VT, had fibrosis on their CMR, and all 3 who experienced sustained VT were symptomatic and developed an episode of non-sustained VT before the onset of VT. 1 of the 3 received an ICD due to presyncope. 1 was scheduled for an EP study, the results of which are not known, and the 3rd was advised to cease competing due to recurrent VT during exercise. Of those who experienced the ventricular arrhythmia, 78% of athletes had fibrosis on CMR compared with 22% of athletes who did not, and that was statistically significant. Now, 2 other predictors of having VT were LV dilation and exercise-induced PVCs. Now, one important finding is that LGE, late gadolinium enhancement, at the RV insertion point was super common. This is also well known in athletes, but it had no statistical significant correlation with ventricular arrhythmias. Both groups had a normal ejection fraction, both had similar and normal RV function, and there were no significant differences in T2 times between athletes with and without ventricular arrhythmia, and no athlete had T2 values indicative of acute myocardial edema, and no athlete fulfilled Lake Louise criteria for acute myocarditis. So my comments. The authors concluded that fibrosis incidence was high and associated with ventricular arrhythmias, and RV insertion point LGE was not associated with ventricular arrhythmias, and sit down for this conclusion, quote, further studies are needed to establish whether myocardial fibrosis itself is arrhythmogenic or, in the case of athletes, indicative of a myopathic process. I like this conclusion. It's humble, and it's different from many of the posts I've seen on social media, which go too far about scaring people about exercise. There's much to say about these observations, but sadly, most are questions rather than answers. First, why was the fibrosis presence so high, almost half of people? And I think the issue here is a systemic bias in this study. It's a selection bias, or more so specifically, self-selection. I spoke to a researcher who does a lot of normal volunteer studies, and he told me that after the fact, many asymptomatic volunteers admit to symptoms that they wanted checked. Now, recall that this study was done in the UK, where getting checked out may not be so easy. So you enroll 100 people who have to agree to get ILRs. ILR is an implant under the skin. To me, this represents a special population who are probably more than just curious. They're probably concerned. Endurance athletes tend to be obsessive, and they read a lot about heart issues in athletes. I would almost consider getting an ILR in this case as a collider bias. You're not looking at a general population of endurance exercisers, but those endurance exercisers interested in monitoring for some reason. All right, second question is, then there's this issue of ILR monitoring. Now, ILR monitors are great. They're always on. They're amazing monitors. They are like pacemakers. They pick up everything. They're far more sensitive than a 2-week ECG or even an Apple Watch. So you have a population enhanced by concern wearing a monitor that misses nothing. In my device clinic, I probably get 3 non-sustained VT alerts per day, 99% of which I say just follow, and I've become increasingly convinced that short episodes of atrial and ventricular tachycardia are probably normal in older people. I don't know that for a fact, but I see it in almost everybody. Indeed, in the VENTOUX study, only 3 of the 100 individuals had symptoms that required clinical action: an ICD, an EP study, results unknown, and an exercise restriction. All 3 of these patients were symptomatic, so clinically I agree 100% with the authors that there is nothing in this data that would suggest screening with MRIs and ILRs. You can go with symptoms. VENTOUX does not support screening athletes with MRI. You can and should wait for symptoms. Now, another matter or question is the degree of LGE. The scar burden was small, only 2%. These are really small scars, and most serious VT that we take care of in electrophysiology comes from much larger scars. Now, I'm not saying that scar is normal. It is true that any scar is abnormal, and we don't know if it is from exercise or healed myocarditis, and we actually don't know the benefit-harm ratio of lifelong exercise. Lifelong exercise is going to be protective against diabetes, hypertension, coronary artery disease, but it may cause these small LGEs in a very small proportion of patients. Again, it's an unknown risk ratio. Now, notice all the comments that I've made so far are questions. This study is interesting, it's intensely interesting, and it's a great effort. But to offer more actionable results beyond don't ignore symptoms, which is an easy thing to tell people, we would need larger samples that were crucially more random in their sampling. Though the authors tried, VENTOUX is not at all a random sampling of heavy exercisers. I'm just thinking out loud, but I can imagine a study wherein you went to an endurance race, a bike race. You signed up every 5th or every 3rd 30-year-old, and you followed them serially, as in they did in Framingham, one of these longitudinal studies, and you do CMR every 5 years for 2 or 3 decades. Then we might know more. But such a study is vast, and it's going to be super expensive. I don't know that it'll ever be done. For now, I recommend regular exercise as if it were a heart pill or AFib pill. You take it daily, todos los días. The vast majority of people I see don't exercise enough. What endurance cyclists and bike racers like to do is not at all for health. It is for fun or for sanity. Whether it is a net harm remains to be seen. But my friends, even if it were a net harm, I am not sure that most of us would stop doing it, because rodents must run on that wheel. All right, next topic is the daily step count. No myths were busted. An Australian group of researchers have published a massive systematic review and meta-analysis of daily steps in health. Lancet Public Health Journal published a study which was covered in 176 news outlets as of this morning. And most of the news headlines say something like the 10,000 step myth has been busted and now 7,000 steps is sufficient. But I think the news stories are wrong. And I will briefly cover the study because it bookends the extreme exercise study that I just covered quite well. This research team had 57 studies from 35 cohorts were included in the systematic review, and 31 studies from 24 cohorts were included in meta-analysis. And they were looking at the dose response in steps and many outcomes, including mortality, CV death, dementia, falls, type 2 diabetes. The comparator and control group was 2,000 steps. And compared to that, those who reported or documented on a counter 7,000 steps per day had a 47% reduction in all-cause death, a 25% reduction in CV disease incidence, a 47% reduction in CV mortality, a 37% reduction in cancer mortality, 14% reduction in type 2 diabetes, and a 38% reduction in dementia, and maybe most importantly, a 28% reduction in falls. Each of those outcomes were statistically significantly reduced with 7,000 steps versus 2,000 steps. My comments. My issue with the study is that when you go to the main figure, the plots with hazard ratios on the y-axis and the step counts on the x-axis, you see a clear dose response of steps and specific outcomes. 2,000 steps is where the hazard ratio is 0. If it's less than 2,000 steps, the outcomes are actually higher, as in sedentary is higher. But as a step count increases, the hazard ratio drops. Now, the authors pick 7,000 steps, I assume because that is where the slope of the benefit seems to plateau. But when you look at the curves, the hazard ratio keeps dropping with more steps. The authors quantify the added benefit of greater than 7,000 steps per day in Table 8 of the supplement. And for all-cause death, there is an added 10% lower hazard ratio with 10,000 versus 7,000 steps. And you see the same thing for cancer mortality and depressive symptoms, an added 10% lower relative risk with more steps. So that's why I don't think any myths were busted. 7,000 steps is fine. 7,000 steps per day is associated with lower bad health outcomes. But for many, including all-cause death, 10,000 is better, statistically significantly better. So if a patient asks, the number is still 10,000, though 7,000 is also good, and 5,000 is better than 4,000, which is better than 3,000. After reviewing this study, the thought came to my mind about European versus American life. It just popped into my head. We have probably 2,000 people working at my hospital. I would say less than 5 people walk to work. Less than 10 ride their bike. When I visited the team in Basel, Switzerland last fall, it looked like more than 75% of the hospital walked or cycled to work. Now, very few American cities are set up for walking, and that's sad. So Americans have to make an effort to be active or to do these steps, and I think it's worth it, and I recommend it in the clinic. For my height, 7,000 steps is about 3 miles. 10,000 steps is nearly 5 miles. The optimum dose is the longer one, but some is better than none. All right, third topic today, I want to talk about rate versus rhythm control of atrial fibrillation. Medscape has a news story this week titled, quote, "Everyone deserves a shot at the American dream, Sinus rhythm." Now, let me just say a few words here about rate versus rhythm control, because this may actually be the number one issue in all of clinical EP. Now, the stimulus for writing such a review piece in Medscape, I think, comes from the PROG 25 trial of lifestyle modification versus AF ablation. I have opined on that PROG 25 on the July 11th podcast. In short, AF ablation led to less AFib than risk factor modification alone, though 35% or 1 in 3 patients in the risk factor modification group had sinus rhythm without ablation. NRF modification led to more weight loss, better glycemic control, better fitness as measured by VO2 max. PROG 25 also found no statistical differences in AF burden nor quality of life measures. The paper sits in the literature as a, quote, positive trial for ablation, but I actually think if health is the outcome, it's a positive trial for risk factor modification. Now, the Medscape article cites a, quote, hybrid approach wherein all patients who pursue rhythm control also get risk factor modification, which I totally agree with and I have to say is underused, at least in my zip code. I think the absolute wrong thing to do is to ablate the AFib and not help the patient lose weight and improve their cardiometabolic health. Because if you do this, you have merely reduced a surrogate marker. You've reduced AF episodes on a monitor. Health is not improved if obesity, hypertension, diabetes, and poor exercise tolerance remain. You succeed as a proceduralist but fail as a doctor in this scenario. The Medscape article goes on to celebrate the benefits of sinus rhythm over AFib. Now, the next logical step is to laud rhythm control over rate control, and here I have a problem. And I somewhat disagree with my friend and colleague Eric Brstowski. Eric is well known for his criticism of the AFFIRM trial and how that trial set EP back many years. But I had the pleasure of speaking in Calgary, and I met the late Dr. George Weiss, the PI of AFFIRM. I think his trial AFFIRM is one of those landmark trials that deserve your attention. It was published in 2002 in the New England Journal of Medicine. 4,000 patients with AFib were randomized to rate versus rhythm control. Mortality was the primary endpoint, and those were the days, wasn't it, when we measured primary endpoints of mortality. Patients in Affirm were like those we see every day, about 70 years old, most with hypertension, a third with coronary disease. At 5 years, they're 23.8% in the rhythm control diet versus 21.3% in the rate control arm. The hazard ratio was 1.15, or it was 15% worse for rhythm control. The confidence intervals were 0.99 to 1.34, so the p-value for harm was just outside the 0.05 bounds, but the upper bound, or the worst case scenario, was a 34% higher rate of death in the rhythm control arm. Now, more patients in the rhythm control group than in the rate control group were hospitalized, and there were more adverse drug effects in the rhythm control group as well. So it was a higher burden arm. Now, Affirm was largely interpreted as showing no differences in the two strategies, but really, I think there was a strong trend for worse outcomes in the rhythm control arm. One of the major changes in knowledge that came from the Affirm results is the importance of maintaining oral anticoagulation. In Affirm, patients in the rhythm control arm who were maintaining silent rhythm could stop their oral anticoagulation. And we would think that's crazy now, but then at that time in 2002, it was the standard. This practice led to a difference in anticoagulation use. It was about 85% versus 70% in the rate versus rhythm control arm. And in fact, Affirm largely changed the view that patients with AF with either strategy should remain on oral anticoagulation. There was a study by Sherman et al., JAMA Internal Medicine, and I'll cite that, found that patients who remained on warfarin were 68% less likely to have a stroke. In that sub-study, a large proportion of the ischemic strokes, 113 of 157 in total, occurred in patients in whom anticoagulation had been stopped, in this case on the basis of reestablished normal sinus rhythm, or had occurred in patients who had a subtherapeutic INR. Now, Eric Prostowski's point about Affirm is it led to too many patients with atrial fibrillation being told that there was no reason to try to get into sinus rhythm. And of course, if you don't try, or if you don't establish sinus rhythm and you leave patients in AFib, it soon becomes impossible to restore sinus rhythm. Patients who have been in AFib for a year or so, it's much more difficult to get them into sinus rhythm. Now, the other problems, or I guess criticisms of Affirm, were that patients had to be able to tolerate rate control. So highly symptomatic patients were excluded, and Affirm should never have been applied to these patients. Many of these symptomatic patients were younger, and it is a serious error to just leave a symptomatic younger person with AFib forever in atrial fibrillation. Now, another criticism of Affirm was that it only included antiarrhythmic drugs, and amiodarone was the most common one used. Antiarrhythmic drugs were all that was available at the time, and we now know that AF ablation is far more effective at rhythm control than drugs. So there's like a bridge to sinus rhythm early on, and many patients can be put into sinus rhythm with rhythm control. Now, proponents of aggressive rhythm control also cite the EAST AF trial, a rhythm versus rate control trial which strongly favored rhythm control. But as I've said many times, EAST AF suffered from serious performance bias issues wherein the rhythm control arm got oodles more interactions with the health system. Here is my take on the decision of rate versus rhythm control. I believe that Affirm still applies. If you have an older person with minimal to no symptoms from AF, rate control is not only fine but may be preferred. But if there are A, symptoms, and B, clues that rhythm control is possible, for instance, the LA size is not ginormous, or the patient can cooperate, and maybe the AF is not more than 2 years persistent, I try rhythm control. But I tell patients that while there is a benefit from sinus rhythm in terms of quality of life, rhythm control is hard. It costs a lot. I'm not talking about money. I'm talking about investment in their time and effort. Patients have to know that risk factor modification is crucial. They will also have to spend a few days in the hospital for cardioversions or maybe drug initiations or ablation. Remember, when you are getting cardioversions and antiarrhythmic drugs and ablations, you're not at work. You're not on your bike. You're being a patient, which is fine. It's an investment, but patients need to know that rhythm control is unlike a gallbladder operation or an appendectomy. Rhythm control is a process that requires a friendship with a cardiologist. It's not one and done. There are also risks to rhythm control. Drug side effects and ablation complications do occur, and my friends, be careful flying close to the sun with rhythm control. One of the biggest mistakes I see in general cardiology is leaping to cardioversion without a plan. Cardioversion of atrial fibrillation is fine, but you have to have a plan for what will happen in a week or a month when the patient is back in AFib. Cardioversion doesn't modify the problem of AF, it just resets the heart. Now, in the end, electrophysiology is here to help. Get us involved, especially when there are symptoms, and doubly especially when there is heart failure. But don't dismiss AFFIRM. It is an important trial that shows that rate control is not a terrible strategy in selected patients as long as you maintain oral anticoagulation. All right, final topic today is a brief one. GLP-1 drugs and observational studies. There's a GLP-1 study that purports to show benefits in cerebrovascular health. It actually shows how observational studies can mislead you. The title of the paper is Neurodegeneration and Stroke After Semaglutide and Tirzepatide in Patients with Diabetes and Obesity, and it's published in JAMA Network Open. And the goal of the Taiwanese group was to evaluate the association of semaglutide and tirzepatide with the incidence of dementia, Parkinson's disease, ischemic stroke, ICH, and all-cause mortality, compared with other anti-diabetic drugs in patients who have diabetes and obesity. This is an important question. The best way, of course, would be to randomize patients, but that would be hard and it's costly. So this was a retrospective cohort study using the electronic health record from the TriNext US network over 2017 to 2024. The two groups in this study were those who took the GLP-1 drugs, either semaglutide or tirzepatide, versus the other groups who took other diabetes medicines such as metformin or sulfonylureas, DPP-4s, SGLT2 inhibitors, and others. Now, this was a large study, about 30,000 patients in each of the two groups. The groups, of course, are not randomized. A doctor chose which of the two diabetes drugs to use. So, since it's not randomized, the authors do propensity matching, which is a statistical adjustment to try and make the two groups similar. These were 57-year-old patients, half male, half female. BMI on average was very large, 40. 70% of these patients had hypertension, and here were the main results. During the 7 years of follow-up, GLP-1 agonist users had a lower risk of dementia, hazard ratio 0.63, had a lower risk of stroke, hazard ratio 0.81, a lower all-cause mortality, 0.70, and no significant differences in the risk of Parkinson's disease or intracerebral hemorrhage. And the authors concluded with this sentence, quote, "These findings suggest potential neuroprotective and cerebrovascular benefits of GLP-1 agonists beyond glycemic control, warranting further trials to confirm these outcomes." Now, my comments. Maybe these drugs are beneficial for cerebrovascular health, especially in young people that like this study, age 57 and diabetes and a BMI of 40. But my friends, this is a hopelessly confounded study where healthier patients got the more pricey and newer drug. Now, how do I know that? Well, there's two clues, and I think these are important clues for all observational studies. First is that the Kaplan-Meier curves diverges almost immediately and they continue in parallel. That's what you'd expect when healthier patients get one treatment. There's immediately better outcomes. If the GLP-1 drug was better than the other drugs, you'd see gradually increasing benefit over time. The second reason that I think this is confounded is that the mortality benefit is huge, a 30% reduction in death. That is outsized, and you might ask how I know that. Well, I have to go back to other studies. In the SELECT trial, which was a randomized controlled trial of semaglutide versus placebo in patients with heart disease and obesity, Semaglutide only reduced cardiovascular mortality by 15%. In the SUSTAIN-6 trial of semaglutide versus placebo, this was in diabetics, semaglutide had no significant reduction in death or CV death, and SUSTAIN-6 was positive because of a composite endpoint that drove positive results. So the second clue is that in these observational studies, when you see that all-cause mortality is super low and the effect size is super large, that's a clue that healthier patients got one treatment. My overall take, therefore, is that GLP-1 drugs induce weight loss. They do modify disease in patients with obesity and diabetes and patients with obesity and atherosclerotic disease. But whether they reduce important cerebral vascular outcomes like dementia cannot be answered by these confounded observational studies. I'm not sure it's worth doing these studies because the only value, I think, is to show readers the signs of bias in non-random retrospective comparison studies. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, just take the time. Give us a rating. Write us a review. These things help others find us. And by all means, if you don't agree with something I said, let me know. I'll make it into listener feedback and I'll learn from it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.